Oh wow, it's been a while. No, that's now our intro. Let's start again. Alright. Welcome back to another episode of NeuroClarity, your audiovisual companion for mastering neurology, one clinical pair at a time. Today, we are diving into chapter 3 of Ching and Cheng's comprehensive review of clinical neurology. We'll be tackling questions 7 to 9. We've done questions 1 to 6. These questions focus on some of the most critical and exam-tested topics, including elevated intracranial pressure, barbiturate coma, and state of consciousness. Whether you're a med student preparing for the boards or a neurology resident on call, this one is for you. That being said, let's get started. Question 7. A 20-year-old man was involved in a motor vehicle accident and suffered traumatic brain injury. He is intubated and admitted to the Neurocritical care unit. An ICP monitor is placed measuring an ICP of 35 centimeters of water. Hyperventilation is started and 60 grams of mannitol is given intravenously. Which of the following is correct regarding therapies for increasing ICP? A. Hyperventilation will produce a change in CSF osmolarity, favoring the shift of fluid from neurons into the CSF. B. Hyperventilation is a short-lived therapy and a rebound increase in ICP may occur. C. Hyperventilation should target a partial pressure of CO2 of 15 to 20 millimeters of mercury. D. Mannitol increases CSF osmolarity, creating an osmotic gradient that will drive fluid from the intravascular compartment into the CSF. And E. Mannitol can be given in a continuous infusion and should be used to target a serum osmolarity of more than 330 milliosmol per liter. What do you think? Now, right off the bat, if you've worked in a neurocritical care unit for at least 1 week, you would know that option B is the answer. Hyperventilation is a short-lived therapy and a rebound increase in ICP may occur. Let's break this down. First, normal intracranial pressure ranges from 5 to 15 millimeters of mercury, which is equal to 7.5 to 20 centimeters of water. And when the pressure climbs above that, it can cause a reduction in cerebral perfusion pressure, and this can compromise cerebral blood flow, leading to ischemia. How do we generally respond? 1. Elevating the head of the bed can help, especially when it is raised above 30 degrees. 2. Avoiding fever, because hyperthermia can actually cause an increase in cerebral metabolism. 3. Maintaining normal glucose and blood pressure. And 4. Preventing complications like seizures. But these are general therapies. Specific therapies, like in our case, includes hyperventilation. Now, hyperventilation will cause hypocapnia, which basically means a reduction in the amount of CO2 in the blood, and that leads to cerebral vasoconstriction. This shrinks the cerebral blood volume and it helps to lower the intracranial pressure. But here's the catch. It only lasts for 10 to 20 hours, and a rebound vasodilation may occur if CO2 levels normalize too quickly. So, it's a bridge, but not a long-term fix. Mannitol, on the other hand, is a classic osmotic diuretic that works differently. It raises the serum osmolarity and it pulls water out of the edematous or the swollen brain tissue into the vascular space. But you don't give mannitol as a continuous drip. It is dosed in boluses of 0.5 to 1.5 gram per kg. You need to keep the serum osmolarity less than 320 milliosmol per liter in order to avoid complications like hypotension, electrolyte loss, and renal injury. Now, here's a pro tip. Mannitol is great if the blood-brain barrier is intact, but it can worsen cerebral edema if it leaks into brain tissue through a disrupted barrier. So, I want you to remember, hyperventilation buys time, but mannitol reduces edema, and ICP control is a marathon and not a sprint. Now, back to our question. We've said our answer is option B. Hyperventilation is a short-lived therapy and a rebound increase in ICP may occur. Why are other options wrong? Option A is wrong because hyperventilation affects CO2 and not CSF osmolarity. Option C is wrong because CO2 targets should be approximately 30 millimeters of mercury and not as low as 15 to 20 millimeters of mercury. Too low can cause dangerous vasoconstriction. Option D is wrong because mannitol increases serum, not CSF osmolarity. And option E is wrong because mannitol is not given as a continuous infusion, and raising the serum levels to more than 330 milliosmoles per liter, that's asking for renal failure. Key pearl: use hyperventilation sparingly and monitor for mannitol related complications like hypotension and electrolyte loss. Next question. Question 8. Hold up. Question 8 is actually question 7 but a continuum. That's interesting. Anyways, the patient described in question 7 deteriorates and his ICP remains persistently elevated. He is currently sedated on propofol and receiving hypertonic saline. Barbiturate coma is induced. Regarding these therapies, which of the following is correct? A. Barbiturates increase the ICP by reducing cerebral metabolic activity, thereby reducing cerebral blood flow and blood volume. B. Barbiturates should be titrated to an EEG pattern of continuous beta activity. C. Hypertonic saline reduces the ICP by producing vasoconstriction and reducing the cerebral blood flow. D. Complications of propofol use include hypertension and metabolic alkalosis. And E. Propofol has a long half-life and has no effect on the ICP. What do you think? Well, our correct answer is A. Barbiturates decrease ICP by reducing cerebral metabolic activity, thereby reducing cerebral blood flow and volume. Let's break this down. Propofol is fast acting, it wears off easily, and it allows for frequent neurological examination. It reduces the ICP in some patients, but be aware of hypotension, respiratory depression, and rarely propofol-induced syndrome, which is a deadly mix of bradycardia, metabolic acidosis, rhabdomyolysis, and shock. Use propofol only with ventilated patients and monitor for hypertriglyceridemia. Hypertonic saline, unlike hyperventilation, does not work by vasoconstriction. It creates an osmotic gradient drawing fluids from the brain cells into the bloodstream, something like mannitol. It is especially useful or helpful in volume depleted patients where mannitol might be risky, but titrate slowly. Too rapid a sodium shift can cause something we call central pontine myelinosis. How about barbiturates? These drugs, like phenobarbital, suppresses cerebral metabolism. This leads to a decrease in cerebral blood flow and intracranial pressure. EEG monitoring is very essential, and you need to titrate to a burst suppression, not a continuous beta activity, which you will see in benzodiazepines. Complications include hypotension, myocardial depression, infections, and hypothermia. Think of barbiturate coma as a nuclear option for ICP management. It's powerful, but it's not without risks. Now, why are the other options wrong? Well, continuous beta activity is seen in benzodiazepines and not in barbiturates, and it is not a treatment goal. Hypertonic saline works by osmotic pull and not vasoconstriction. Propofol causes hypotension and acidosis and not hypertension or alkalosis. And propofol reduces the ICP and has a short half-life. Option E is completely off. Keep her. Barbiturate coma should be your last resort, and when you use it, monitor the ECG, monitor the blood pressure, and the immune status closely. Next question. Question 9. During an acute illness, a patient is found in a sleep-like state, not responsive to verbal stimuli and poorly responsive to tactile stimuli, but he can be aroused by constant and continuous noxious stimulation, and when aroused, his cognitive function is significantly impaired. When the stimulus stops, he goes back to his poorly responsive state. Which of the following states of consciousness correlates with the findings on this patient? A. Coma. B. Stupor. C. Locked in state. D. Unresponsive wakefulness. And E. Delirium. What do you think? The answer is B. Stupor. Let's compare. Stupor is a pathologic reduction in consciousness. This patient is unresponsive to most stimuli. He is aroused only with vigorous repeated stimulation like sternal rub or nail bed pressure. He is cognitively impaired when briefly aroused, and he returns back to an unresponsive state once the stimulus stops. Coma, on the other hand, is deeper. There is no arousal even with strong stimuli. Well, you may see some grimacing and posturing, but that's all there is to it. There's really no purposeful movement and no response to environment. There is something we call unresponsive wakefulness, which was once called vegetative state. In this condition, the patients have sleep-wake cycles, they open their eyes, they may appear awake, but they have no conscious awareness of self or environment. There is no purposeful response. And lastly, in locked-in syndrome, they are fully conscious but completely paralyzed except for vertical eye movement and blinking. Usually, this is from a brainstem stroke that affects the pons, and it is a devastating condition often confused with coma unless eye movement testing is done. In our case, stupor is a right call. So, now that we have done this, let's take a final recap to lock this in. For intracranial pressure management, hyperventilation reduces ICP briefly through hypocapnia-induced vasoconstriction. Mannitol works by serum osmolarity and not CSF osmolarity, and you need to watch out for rebound and monitor the labs. For barbiturate coma, this lowers the ICP by reducing cerebral metabolism, requiring EEG monitoring for burst suppressions. Propofol is rapid but comes with risks, and hypertonic saline is a helpful osmotic tool. For state of consciousness, stupor is arousable only with strong continuous stimuli with impaired cognition, and please do not confuse stupor with coma, unresponsive wakefulness, or locked-in syndrome. And that's a wrap on today's episode of NeuroClarity session. We did 3 power-packed questions with 3 key clinical concepts delivered straight from Ching and Cheng's comprehensive review of clinical neurology. If you found this helpful, you can share it with a colleague or a resident who is on night shift duty. For more brainy breakdowns and bit-sized brilliance, stay tuned and subscribe. Until next time, keep your thinking sharp, your reflexes brisk, and your ICP under control. This is NeuroClarity. Stay clear and bye for now.